Okay. Please take a seat. Thank you very much. I hope you have enjoyed the coffee break. Also, I'd like to highlight for the people connected remotely that if you want to do any kind of question, please put it in the Q&A, okay? And we will share it to the panelists. So with no more delay, we're going to start the roundtable with the vision of the hospital of the future with representatives of the public administration and the MedTech industry. So I'm going to give the floor again to Germán as moderator of this session. So thank you very much.
Thank you, Paula. Well, I expect that you have had a good coffee break, a refreshing coffee break. And now my ambition is to go into practicalities and go into tangible things that are derived from the project. It's for me a pleasure and an honor to have these two invitees. One is coming from the public sector, and the other one is coming from a competitor of Medtronic, from the industry, from Siemens Healthineers.
And also a partner.
So we have José María Vengazones, that I think is a very interesting profile, because as a background in education, he's a medical doctor and engineer.
Yes, two engineerings, telecom and industrial, and medical doctor.
So, as you can imagine, it's going to be exciting to really extract the knowledge from José María. And he's the Deputy Director of Planning and Operations in Digital Health in the Comunidad de Madrid, in the region of Madrid. And María García is Business Development in Siemens Healthineers. She has a very, very long experience in the hospital sector and in the areas that we are going to discuss today. So thank you for being here.
Thank you very much.
Let me spend a few minutes contextualizing this roundtable. As you see, we are going to talk about hospital of the future, but I want to put a perspective. This is a moving target, hospital of the future, as you can imagine. It's not the same, the definition of hospital of the future that we had 6 years ago when we started to conceptualize the project, to most probably the idea of hospital of the future that we have today. So 6 years ago, well, it was about what you have seen as a development in the project, AI, robotics, sustainability. So it was very hospital-centric in the sense that it was about the building of the hospital, what's happening around the building of the hospital. Today, if you make a search about hospital of the future and you compile some literature about, it's much more about virtual hospital. It's much more about minimizing the time that a patient spends at the hospital. It's about really how to prepare citizens and patients to go through the hospital and how to really continue the care of the patients once they are at their homes. So it's more about shifting care from the building to what is hospital patients' homes. And it is not a casualty that this is happening in these 6 years, because 6 years ago we were talking about, okay, we have chronicity, we have the wave of chronicity and what it does mean from terms of comorbidities and healthcare expenditure. And this was just always talking about what is going to come. But what I sense these days, and I have the experience of talking to many hospitals, to many C-suite hospitals, to institutions, to politicians, what I sense today is that the wave is not anymore coming, it is here. The flood has risen, and now there is a pain in the system because there is a staff shortage. We were commenting about in the last roundtable. It is a reality. Staff shortness is a very big pain of the system. It brings, or it carries the need of to be much more efficient, the need of just taking advantage of the knowledge of our medical professionals and our healthcare professionals and not to overwhelm them with administrative processes. So it's much more about improving outcomes, at the same time generating efficiencies and putting the patient much more in the center of the stage than it was in the past. So there is a real change, and this is almost 6 years ago, only 6 years ago, that we are really sensing this shift in the concept of hospital of the future. Pandemic has accelerated the process dramatically, both in terms of adoption or just diminishing the barriers to adoption of new technologies. There is much more willingness to use this type of technologies. And also there is a real understanding that we need them. We need them. So, with that introduction, I just want to go into the center of the discussion, and we are going to go into the discussion what does it mean from the practical perspective to go into the direction of virtual hospital. And I think the challenge that we have, or the opportunity that we have, is that technology is there. We have the appetite to use this type of technologies. There is the willingness of everyone in the system to go into this direction. There is a real big opportunity to be more efficient and to have more outcomes. But which are the barriers? The barriers is that we are still living in the old-fashioned way, so with budgets that are following the normal way of doing things in healthcare. We have a lot of cultural barriers that we need to overcome, and we need to work all together into really facilitating or overcoming these barriers. So, having said that, for the public sector, how is public sector shaping the framework to accelerate in reality, in real practice, not theoretically, in real practice, the adoption of all this new mindset?
Okay, thank you. It's an excellent question because, as you said, it's very important to increase the efficiency inside the hospitals. I studied first to engineering and then as a hobby medicine. And when I was in hospital, I was analyzing how inefficient were the processes and say why the data is in different systems and why a medical doctor has to write and not watch face-to-face to the patient. The relationship between medical doctor and patient, we are losing this relationship. So why don't we use speech-to-text? Why don't we use some type of artificial intelligence so that we can improve the data inside or inside the electronic records? Because I've been in different healthcare systems and the typical medical doctor has just a few 10 minutes, 5 minutes for each patient. It's impossible to read everything. They are like CEOs. They should have a resume, a dashboard, and in 2 minutes understand how is the context of this patient, and then interact with the patient directly, and an intelligent system include this data curated, structural inside the systems. Because and also each hospital is different, and in Spain, each community has different systems. So there is not a compatibility, a real compatibility. So why don't we do something to improve? And we have the technology to do that. So, for example, as a public And in Spain, we have a strategy. We had a strategy 2021, 2026 with different lines. One is, I think, very, very relevant in this area. One is about primary care, but also another is about personalized medicine, digital personal medicine, and also about data spaces. Why data spaces? What are we doing in the data space in Madrid? In Madrid, we have a real data space. Where we have a Cloudera, we have a data governance office for 2 years, and we have ingested, like in April, was about 13 billion data registers inside. So we are ingesting all the data from hospitals, for all the hospitals, from primary care, analytics, and this is a huge challenge, it's huge. And it takes time, and you need resources. You need very skilled professionals in data governance. We also have the interoperability office. Why? Because we have to interoperate a lot of systems inside the hospitals. And what is the challenge? We have to get all this data together. We have to curate this data, and we have to design the different use cases so that the medical doctors inside the hospital can improve their jobs, but not doing manual activities. The system should show them data so that to help them to take decisions. So if you have a patient and 10 minutes, if you spend just 2 minutes to see a dashboard as a CEO, and you talk with the patient for 5 minutes, the patient feels that you are, as a medical doctor, taking care of his health. And another, for example, another initiative is telemedicine. If you use telemedicine, you can empower the patient so that in their home, you can measure the data. If you ingest the data, manage the data inside a data space and use artificial intelligence, you can be reactive, not reactive. So you can advance, you can communicate for the appropriate channel with the patient. Each patient is different, so that the patient can come if there is a problem before the problem happens. And what is the problem we are facing? We have the data lake. We have one of the biggest data lake in Europe in healthcare. Okay, perfect. But we don't have the capacity to accelerate, to use artificial intelligence. Why? Because we talk with NVIDIA, we talk with Cloudera, we talk with different manufacturers. The problem is that at the beginning you design a data lake for dashboard, to create a dashboarding, to do some research, but the infrastructure is not ready for use artificial intelligence at the scale. In real time, at the scale. You need a strong infrastructure. You have to design technically to access data very fast in a network and process the data and use the efficient algorithms. You have a lot of different types of algorithms. And now even there's a discussion about generative AI. You can use generative AI to resume, for example. So we are thinking about to create a use case in just short time for primary care to process 400,000 resumes every day for the 15,000 medical doctors in primary care, for example. And it will help them to spend just 2 minutes to understand the context. And then we are thinking about to use a speech to text and translate this data, validated by medical doctor, always validated by medical doctors. The technology is not magic, it helps you, but there is always a medical doctor to ensure that the data is correct. And we also are thinking about to use artificial intelligence in image in hospitals. Why? Because you can save about 70% of the time of a radiologist in redacting writing the report. If you can associate an image and process the image during the night, you have the agendas, so you can process at night. And in the morning, when the radiologist goes to work and the machine is working all the night with patients, taking the images, the radiologist could use this tool to help them to improve the efficiency and validate and modify, if necessary, the report. So you can use with a high impact inside the hospital, and there is a lot of use cases. But I will stop here because there's another project very interesting about genomics. What about genomics? What about personalized medicine? In Madrid we have a CEMAC. It's the Centro Madrileño de Genómica, Madrid Regional Genomic Center. Okay. We have ingested all the data from all the sequencing from 6 or 7 the biggest hospitals, which has the Illumina systems and Thermo Fisher systems. And then, it's phase one. Phase one, what means? Is crowded. I mean, we don't have enough space because we are talking about terabytes for patient. And what is the next step? We are talking about 5 or 6 companies specialized with their platforms, and there is not one mature company. We are in the cutting edge. There is research about how to use the data in genomics. So we have to do the same as with the data lake. We have to manage to create the metadata to governance the genomic data. And in Madrid, we have a special situation. We are doing all on-premise. What means on-premise? I can save millions of euros if I use the cloud in genomics or also in image processing. I will spend millions of euros a year. If I can manage to use algorithms to develop algorithms inside the community and use these algorithms inside, not in the cloud, inside, I will prevent I will comply all the compliance about data protection. I can process 24 hours a day, all the days. So I have the infrastructure, I know how much it costs, and there is no hidden cost as in the cloud. So I think our strategy is correct, but it's complex because we have to do a lot of engineering, and we have to we have to manage the strategy, and the strategy, but it's not fixed because the technology evolves. So 1 year, 2 years ago, there is no generative AI. Generative AI won't solve the problems. The classical machine learning in most use cases is better, but in some cases, generative AI can help us. So we must be prepared to modify, to adapt our strategy to the technology, to the needs, to the society, to the law, because the law is changing. So we have a huge challenge in Europe because the regulation comes from Europe, Data Act, Data Governance Act, Artificial Intelligence Act, the new regulation for the data space in healthcare in Europe. And we must be prepared in 1 year. It's very complex because we are working on this for 2 years, and for us it's almost impossible to achieve all what the regulation will tell us. But we are in the process, and we have an experience, and we want to share our experience with other administrations, because the problem we have in the administrations that we are not private companies. We don't have a huge amount of money. We have very restricted budget, so we must be very carefully how to design the strategy, how to invest the money, because if we use the cloud, we can lose all the money from Europe that comes for healthcare in 1 year. If we invest on-prem, we can use this for 10 years. This is the difference. So it's very sexy, the cloud. All the algorithms are in the cloud. The best algorithms probably are in the cloud, but in Spain there is a new strategy that will start on 2026. I have all the information because it was last Friday we have a meeting. And there are three very interesting. 4. One is about artificial intelligence, and what we would like to do. We would like to collaborate with researchers, and we would like to manage the algorithms so that to comply all the law to use in medical practice. And we don't want to spend the cost for one algorithm, for example, for prostate in Madrid, will cost us more than 1 million euro a year. And we can, if we manage the algorithms, but it's complex, so must be nationally or even in Europe. neuro level, because we have to manage the life cycle of these algorithms. We have to test, sometimes we have to retrain. So we want to, we need to use this technology to improve the efficiency. And we have to save money if we can do it. Or also we can collaborate with companies. But it's so, the moment is an excellent moment, but it's not mature. I talked with a medium-sized company with an excellent algorithm, and I asked, how much will cost us this algorithm in Madrid? And say, well, there's a pilot, it costs, I say, okay, this price is too high. 20 euros for one processing is too high for us. Could be possible to make an agreement for a fixed price to use these algorithms as many times as we need for, I don't know, 300,000, I don't know. Mm-hmm. And said, we don't know. We are not ready, it's not mature enough. So we are in the process. And in genomics, the same. We are working national level to evolve the thematic in Madrid, and we have to share the variants in a national level. And there is also another project called UNICAS. UNICAS is for rare diseases for children. We are co-leading this project with Catalonia, 2 regions, Madrid and Catalonia. And we realize how complex it is to design a new system for interoperability so that a patient from children from one small village in one region can be assisted by the best professionals in national level in this rare disease using networks. And it will help also to improve the efficiency, because I read something that about to detect one rare disease could cost about 7 years to diagnose. Imagine that this disease could be diagnosed in less than 1 year and start the treatment at the beginning. So I think we have a huge improvement, and we have to manage all the funding we have, all the collaboration with companies, with research, with universities, between regions, between countries, because we can use the same algorithms, we can use the same methodology, we can interoperate. In Europe, we have also the EU interoperation, I think very, very important also. But the regulation is very important for us, very, very important. We can use the artificial intelligence and fail in the compliance. So we are very, very carefully how to use. We could use it before, but we stopped. Why? Because the Artificial Intelligence Act started on August this year. So now we're in the process to design all the methodology and the processes and the validation before to start. And before to start in one small proof of concept. Mm-hmm. And after this, we probably can use it, and it will have a huge impact in efficiency in hospitals and outside the hospitals. Because when you have the genomics from one patient, the knowledge evolves. I mean, the research is continuously, they are researching continuously, and they find the new variants and relationships with some diseases, some illness, and you can have a patient in their home, you have their genome, and you can be proactive and say, okay, please come to the visit to the specialist, because maybe we have to check if you have or not this disease, so that maybe we have to change your medication. Mm-hmm. So I think the answer is, are we working in the public administration? Yes, very hard, very hard. It's very complex, yes. We need help, yes, and collaboration. We need collaboration. We can do it alone. Okay. Thank you.
Okay. Well, as a result of the answer, I think I'm going to close my guideline here. And I'm going to react to that. And in my reaction, I'm going to ask the help from Maria, because it triggers to me the perception that this is an overwhelming activity. You have a huge potential. You know that you have a huge potential, but you are overwhelmed by how to steer all this potential. Seems to me that you are setting an infrastructure and you are really thinking about how to extract the potential of this infrastructure. But innovation is all over the place. Companies are innovating all the time. Companies are investing a lot on this innovation, and it's, I think they help just to reduce the cost of development that public administration should face if they don't have this offering from the private sector. So Maria, how do you see your company really evolving in this area of producing virtual tools, in producing predictive tools, and how do you see the difficulties and the barriers just to interact with the administration that they need your tools and our tools, they need it. But at the end of the day, there are some barriers just to introduce those tools into the public administration, because we talk about collaboration. But at the end of the day, companies have products, invest in products, and they want the products to be impactful. How do you see what you produce as a company in interaction with the demand that is having the administration?
Well, it's true what you said, barriers. Something that from a private perspective, we consider the public as a customer. I mean, the healthcare system is a customer, and we want to sell our products and our innovations. But at the same time, then you, and let me be in this so Spanish, you think about you are a patient, and you think like a patient. And as a patient, you demand to the healthcare system. So combining those two things, at the end you have a great portfolio, a great portfolio in which you have innovations. We have invested a lot in innovations, but at the end, the problem is how to adopt these innovations. And when we define a project, one of the things that we are focused on in order to support you is to focus on how to adopt, how to make the change, how to ensure that this new technology is going to be used, because that's key. How many times we have technology in a customer, in a hospital, in one of your hospitals, that is not used. And that's something that from the company perspective is not good. Because if you don't use the new technology, the problem is that this technology is going to be in the little. It's going to be rubbish. And this is not the aim. The aim is to be able to use it, to adopt it, and then be able to evolve it. I mean, to redefine it again in order to improve. So I would say that from any private operator in healthcare, we need to support them on being able to adopt the technology in the correct way and in a sustainable way, which is something that for us as health engineers is key. If we don't consider this sustainability thing from scratch, from the very beginning, when you define any product and any technology, what we are going to face afterwards is going to be a really mess. And the ones suffering that are going to be them. Yes. So these are the things that we can collaborate, not only providing technology, but also influencing how to use it, influencing that it's being used and that is sustainable, contributing to the sustainability of the whole system.
Mm-hmm. José, how do you see from the public perspective this mandate from the European Union and the European Health Data Space in just going into the direction of using data for primary use, but also for secondary use? Yes. And not only for research, but for innovation. That is a mandate from European Health Data Space. So how do you see really the public administration realizing this mandate from the public administration and interacting with the rest of the ecosystem in the healthcare?
It's a great challenge, an excellent question. We have to do it, it's a mandate. So we have to manage how to use this space to innovate, to use in primary and secondary use. In this moment, as we are working for 2 years, we have faced a lot of challenges. We have problems, technical problems, methodological problems, data quality problems, interoperability problems. It's extremely difficult to achieve all what the regulation tells us, but we have to do it. So we have to collaborate. We don't have, we can, as the Lord of Rings is our treasure, no. It's to innovate, it's to use for investigation, for research, for secondary care, secondary use and for primary use. Our data lake, for example, we are using in this moment from secondary use and from management, not also as primary care, but we have to do it also for primary care. In the national level, we are thinking about secondary use, but it's not mature. We are working on. We have just created the editorial committee in a national level. Right now, it's not yet. Created, but it will be created during this year. So I think that it's very, very important to use the resources we have to innovate. We have to innovate. We need your help to innovate. I'm very new in this position. It's just I'm here since June this year. So I found a huge amount of challenges. I tried to manage to put order in because I found what you said. Okay, why don't we use? I asked why we have an algorithm and we don't use it. Why? No, this is the question. Why? We have some device from a company and it's not. They have tried. They tried this device and it works in one hospital. Why don't we expand this to other hospitals? It's about money, it's about management. Sometimes it's about management, about communication. So we have to improve the communication. We talk with professionals, with companies, and you can give us advice. Why don't we use, but we have a huge problem with contracting. We don't know, but for me, the worst is the contracting. Why? Because we have to follow a regulation. We have some funding from Europe. Will be audited when it finishes. We have limitations. We can contract professional services in some cases. So, for example, we have about 2.5 million for research for primary care, and we support them with our data lake. But the surprise was that when they gave the money, said you can contract professional services, and we said what? If we can contract experts in data governance and on artificial intelligence, it's impossible to manage in 9 months this project. It's completely impossible. We can do it. We have team to do it. But if we do this research, we have to stop other projects for primary care and hospital. So it's about resources. It's about management. It's about contracting. And also because when we contract, we have to evaluate. It's very complex to evaluate. Why? Because most companies you have wonderful products. And why should we select one product instead another product? It's very complex. We have right now a challenge with central image project. All the industry will go. And for me, will be a nightmare. Why? Because I don't know, I'm not an expert. Will be some experts evaluating, but the project should be implemented in 1 year. And it will cost, probably we'll have less than 9 months to implement this project, for example. So there are a lot of challenges. It's not one challenge, a lot of challenges, but we can do it. I'm sure we can do it. We have the resources, we have the knowledge, we have the technology, we have the funding to do it. So let's do it. This is the problem, the management. Hours, working 12 hours a day, 14 hours a day to push things, but I'm sure we'll do it. To comply the regulation in national level, it will be very hard. I think Madrid will comply earlier than other regions. But in this case, I would like to help other regions and even other countries, because with lessons learned, we learn a lot failing with mistakes. And we can explain to take care about these mistakes, avoid these mistakes. Try to, for example, in data governance, I belong to DAMA. It's an international organization for data governance, and I represent public administration in Spain. So we have different lines about healthcare, but about use cases, about compliance. So we have different working lines, and in all administrations we have the same problem. Not only in healthcare, in all administration we have problems because there's a shortage of professionals in data governance and in innovation. So I think we'll in 1 or 2 years we'll be able to use the data for innovation and for investigation for secondary use and primary use. But it will be hard. It won't be easy. I don't know if it's my perspective. I'm working all day with this, about to try to comply this regulation.
Okay, Maria, I want you just to be my thermometer of my previous statement on how things have evolved in the last 6 years. So how do you see the sensibility of healthcare professionals at hospital with the type of tools that you were offering at that time, and versus what is today and the offering that you are bringing to the table? Are they really much more sensible that you sensed 6 years ago? And are they using those tools to really generate better outcome and higher efficiency?
Yes, because I think pandemic changed everything and changed the mind of each and every one. So the concept that they had about technology prior to the pandemic and now is totally different. And I don't want to talk about the different generations in the different medical doctors, because it affects. It's another factor, another element that you have to take into account. But it's true that there's a different understanding on how medical practice should be. And there's a different understanding on how to use the technology. And for example, if you think about artificial intelligence, artificial intelligence was here in the hospitals prior to the pandemic. But suddenly, during pandemic, we realized that we can do lung screening with the artificial intelligence that we had at that moment. And suddenly with pandemic, that was a boom. Now we have the reaction, and you have all generations of radiologists saying, oof, what's that? Are they taking me out? But there are another ones that really perceive that this is a support to, as it was said in the previous session, to free time to be used in what is really meaningful for them. This starts with, the young generations that are teaching the rest of the generations inside the hospital how this could be a support, not a fear. So I would say that it's changing. Now the concept is really different. Now we are able to put in the market in a quicker way a new technology, and maybe the photon counting thing that is happening in imaging is an example, because prior to that we were coming from the standard CTs, and when the next generation of CTs came based on on informatics, not on the number of detectors in the CT, it was difficult to be explained. And it was difficult to put that type of product in the market because the doctors were demanding the same as previous. I mean, then they say, this informatic thing is not what I need. No, but you need quality of image. No, I need much more detectors. No, you need quality of image. And that took time. Now with photon counting, it has been, I would say, much more easier because they were much more prepared to see the advantages of the new technology and to really perceive how this precise technology would support them. So yes, it has changed, and it's really something that we have to now push because we have a window that we have to use in order to put the new technology there because now they are listening. If we are not, we have the challenge of giving an answer in this moment, because if you don't give an answer with the technology that you put in the market, really making a difference, it's when then we have a problem, because they are not going to trust on us for the following years. So it's good, but at the end, we are responsible of really giving an answer to that.
José María, do you really see a push from the administration for the virtual hospital? So just to minimize the time and the stay of patients at the building of the hospital?
Yes, well, it's not easy. It's not easy because we have to change. Someone talked about change management. Change management is very important. What I think is that the patient, because I have a family grandmothers, grandfathers that they were in hospital and then in home. If you can manage remotely a patient with sensoring, with no intrusion, transparent for the patient feels better in home than in the hospital. If we have the technology, we have the networking, we have the AI, we have the sensors to do it, and we can save a lot of money thinking about the money. Okay, how much cost me a bed in a hospital? How much cost the professionals, the salaries? I have a shortage of professionals, as someone said before, is true. So the only way to maintain and improve the quality of the healthcare service, the only way is to use technology to have excellent professionals and to use this model so that the patient could be not hospitalized in hospital, but in their home and with more freedom, because I think about people I know and how bad they feel in the hospital. So we can improve how they feel during the process in the medical treatment. So I think that we are going to move to this way, but it will take time. It's not easy. Mm-hmm. There are a lot of processes. The system sometimes doesn't work. There's barriers. Some people don't trust. They want to go to hospital, but I think in a medium time, probably we'll see more patients in their home, because we have to test the systems. If we test that the healthcare improves the quality even in the patient's home, and professionals have tools to manage these processes with the patient, the interaction, the communication, we can achieve it, but this is difficult. It's not easy.
This is already proved. So there is a lot of literature in this direction.
Then is to take the decision, and it's not easy, because imagine there is one patient with a problem in their home and the system doesn't work. Imagine. So I think it will come, but not in next year. Mm-hmm. It will come. And probably with developing the technology inside the hospital, we'll have more experience so that the patient you can manage the patient in their home with more data, with more quality, with less errors in the data. Sometimes the problem is the data quality. If you don't have quality in your data, you can manage a patient neither in hospital nor in their home. But if in hospital, you can interact. But in their home, if you don't realize, you can act. So this is, I think, this is the main problem.
Yeah. Maria, there is a real conviction in your company that there is a movement into this direction. So is the company realizing of this direction and is generating strategies to really harnessing this opportunity?
You mean exactly the patient monitoring?
The direction into,
or the
let's say, the virtual hospital concept.
Yes, and 2 years ago, if I'm not mistaken, we defined a concept of the hospital of the future in the company that was based on the concept that you are going to be monitored in a very seamless way, very natural way, not the one that we have right now, the solutions that we have right now, in a very seamless way, a natural way, that everything is going to happen without annoying the patient or the citizen. So, and everything is going to be predictive, and everything is going to be from the very beginning define how it's going to happen. Why? Because the path that we have started is the path of, for example, focus on screening with the data that we already have. If you go to the hospital and you are taking an X-ray from your chest, with that data, you can have many information that is going to be processed, and then you will have another way of, you will be analyzing in a parallel way of your process, your clinical process. So it's made of getting all the data regarding the patient and really starting to analyze that in parallel in the back. Companies like mine or like yours, we invest a lot of money on technology, but we also have to invest in, for example, access to care. When we talk about the hospital of the future, we are talking about, let me say something of the good countries. And it's true that we have to consider the healthcare from that point of view, that we have a hospital that we don't want to go to a hospital, we want to be at home, to be monitored, to have all the information that we need doing your daily life as you want. Not everybody has that opportunity. So we have to promote to define the technology for not only the hospital of the future, but also the access to care. So from that spectrum, we are focusing on both directions. We think that not only providing technology like for example, digital twin, in the future, we will have a digital twin of ourselves that would predict everything about us. But at the same time, and in the meantime, we need to solve the different things in the path. And that's access to care, and that's sustainability, and those are the other elements that you have to combine. The future, look beyond, being different, and think about the future, but covering the steps in between. So us as a company, we try to cover both dimensions, and we really think that we have a readiness from the customer side. We have a readiness from the healthcare organizations to adopt technology. So, as I said before, we have to really take this moment as a good opportunity to start sharing and start collaborating much more than what we are used to. Yeah.
But in that regards, I have a concern. And listening at you regarding all the infrastructure that you are deploying, do you see administration as developers of technology and infrastructure?
Not. Sincerely, I think administration is very hard inside. I'm a civil servant for 2 levels of administration, and I don't see. There are some civil servants, very innovative, very creative, but it's not the typical. Civil servant, the administration is regulated. Everything's regulated, and we don't like risk, so we manage the projects. But as maybe we are not the best in the administrations to innovate, but we can use in companies to help us to innovate, but to improve the innovation. I mean, not just one product, to innovate seriously. I mean, to design how the process should be redesigned. It's not about just to translate one process to digital process. No, maybe we have to transform, to improve, to automate the administrative processes, to measure everything. If we can measure, we can implement, we can invest. If we measure that if we use this technology, we can save 10% of the cost, probably we'll invest in this technology. So I mean, the administration must adapt the innovation, yes, because we have to do an excellent service to the citizens. The name of civil servant means to give service, good service to the citizen. So sometimes I use this expression, if we are with other civil servants, to convince them, okay, we have the duty to serve our citizens and improve the services we give them. So the answer is yes, we have to innovate, but we can innovate alone. We need your help, and we need the help from innovators, from companies, from universities, and we have to create a type of a cluster or something to collaborate, to share initiatives, but also we have to take care of the money, how much costs. This is the problem. This is a red line. If it's very expensive, maybe we have to do it, but we can do it because we don't have the money to do it.
Yeah. Very good. So as a summary, a final comment, what I perceive is the need is understood, the need is there. There is a momentum. There is many technology and many possibilities, huge potential there. But there is an overwhelming task and activity in front of us. So we need, yes, the contribution of every one of us, many other stakeholders in the system. I think ODIN project is a great contributor to this effort. And as Leandro was telling me during the coffee, this is the moment of educating people, creating, yes, the culture of harnessing this opportunity. And well, I strongly believe that virtual hospital is to become the central piece of the hospital of the future. So thank you very much, José María. Thank you very much, Maria. And thank you for just listening to this conference.
Thank you very much once again, Germán, María, José María.